Hi class, my name is Abreu Henry and my presentation is on the Barlow and Ortolani test. The Barlow and Ortolani test are part of the musculoskeletal physical examination for infants to evaluate for developmental dysplasia of the hip or DDH. DDH is caused by improper acetabulum development, which is the socket that encloses the femoral head. Long-term problems such as chronic dislocation and early hip osteoarthritis can be avoided with early diagnosis and therapy. The symptoms might range from slight hip instability to complete dislocation. A combination of genetic, environmental, and mechanical variables all have a role in the multifactorial character of DDH. Risk factors include being female, family history, higher birth weight, breech positioning, and uteropostural deformities. The left hip is usually involved in newborns. Swaddling has been one of the newer factors noted to be a contributor because of how it keeps the hips in an extended and adducted position. I put a link to a healthy swaddling which allows more freedom of the hips and legs and decreases the risk of DDH. Hip formation relies heavily on the relationship between the femur and the acetabulum. DDH occurs when improper contact between the two is lost in utero or infancy. In utero, the growth of the femoral head is faster than the acetabulum. This means that the femoral head will not have enough space during development, and any little disturbance in that process can result in an unstable hip. A hip examination is an essential part of a well child exam. The Barlow and Ortolani tests are performed up until the child begins to walk. Just note that after the first 2 or 3 months of the life, they become less reliable due to tightening of the tissue surrounding the hips. For older infants, tests like Galeazzi or Klissick are used. The Barlow test is performed while the infant is supine. Hold thumbs against the inner mid-thigh and fingers around on the sacrum and flex knees. Adduct the hips while applying gentle pressure down. A smooth motion during this maneuver would be normal in a negative Barlow. With a positive Barlow, the femoral head would slip from the acetabulum and the dislocation would be palpable. It is important to be gentle and to examine while the infant is calm as to not cause damage and to examine one hip at a time. After releasing pressure, the hip would typically relocate spontaneously. The Ortolani test is done after the Barlow test to reduce a dislocated hip. The infant remains in the supine position and the examiner's thumb is placed near the lesser trochanter while the second finger is placed on the greater trochanter. While flexing the hip and knees, abduct and gently push up with the fingers that would place over the trochanter posteriorly. This makes the femoral head lift back into the acetabulum. No palpable or audible discrepancies are considered normal. A hip click that may be heard but is not felt is also considered normal. A positive Ortolani would be indicated by a palpable chunk while the maneuver was being performed.
Barlow test, I'm going to stabilize the other leg because the maneuver should be done one at a time. My thumb is going to be in the inner mid-thigh and my fingers are going to be around the sacrum. We're going to flex the knee and we're going to adduct the knee while applying gentle pressure down. A smooth motion is a negative Barlow. The Ortolani can be done as a continued motion. Just make sure the outside fingers are on the greater trochanter. We're going to flex the knee and abduct and gently push up with the posterior fingers. And a smooth motion is a negative Ortolani.
In one of the websites I found, an orthopedic physician had this mnemonic as a way to remember each test, which I really liked. We're going out tonight, and I added to the bar to remember that it's the Barlow and it's the first maneuver, and that just sludges the bone out of the acetabulum, so it goes out. Then once we have been out, now it's time to go home, and the O is on once is for Ortolani because that's typically what happens after you go out. So the Ortolani again is the bone being reduced back into its socket. The degrees of instability are listed here. With a dislocated hip, we would get a positive Ortolani because we would be reducing the hip back. A dislocatable hip would be a positive Barlow only, and a subluxatable hip would feel unstable but would be a negative Barlow exam. Referral to an orthopedist is warranted for any positive or inconclusive exams. Ultrasound should be obtained if there's high suspicion of hip dysplasia from a physical exam or significant risk factors. An ultrasound is only indicated after the infant is 6 weeks, since prior to that there are higher risk of false positives. The usual treatment for a reducible dislocation in infants is the Pavlik harness and radiographic monitoring. Older children with hip dislocation would require manipulation or an open reduction. Thank you for watching my presentation, and let me know if you have any questions.